Let's be honest, it's the question you get a dozen times a day every fall and winter. What should I take for this nasty cold? So in the next 5 minutes, we're going to cut right through all the noise. We'll build a solid, evidence-based framework that will make your next patient consult way faster, clearer, and a whole lot more effective.
Okay, picture this. A patient shuffles up to the counter, they're feeling absolutely miserable, and they ask for something strong for their cold. We've all been there. This explainer is your direct answer to that. It's about turning that vague, desperate request into a specific, evidence-based recommendation that actually helps.
So here's our game plan. We'll start with the foundation, making sure it really is just a cold. Then we'll hit the core principle of treatment, build out our first-line toolkit, and then tackle the tricky stuff like special populations. After that, a quick rundown of what not to recommend, and finally, we'll wrap it all up with the key takeaways you can use today. Okay, first things first. Before you recommend a single thing, you need to be pretty confident that what you're dealing with is a straightforward case of viral rhinitis, the common cold.
The biggest clue is the onset. A cold usually creeps up on you, right? A sore throat one day, a runny nose the next. Influenza or COVID, on the other hand, well, they often hit you like a ton of bricks. You need to listen for those red flags: a sudden, really severe start, high fever, intense muscle aches. If you hear any of those, your job is simple. Recommend they see a doctor.
So once you're pretty sure it's a cold, your entire counseling strategy can be built on one simple but really powerful idea. And here it is. We can't cure the cold, so we don't even try. The goal is just targeted symptom relief. This one idea changes everything. It means we resist the urge to grab that shotgun combo product, and instead, we ask the most important question. Of all the things you're feeling, what is bothering you the most right now? So, with that in mind, let's build out our evidence-based toolkit for actually tackling those specific symptoms head-on.
This is where we put that core principle into practice. For pain and fever, simple, analgesics. For that constantly dripping nose, rhinorrhea, intranasal ipratropium is a great option because it's super specific and doesn't touch congestion. And for that number one complaint, the stuffy nose, we turn to our decongestants.
Now, when we talk decongestants, topicals like oxymetazoline are usually the way to go for most adults. And why is that? Well, they work faster, they work right where you need them, and you get way fewer systemic side effects, like insomnia or a racing heart, compared to oral options. But, and this is a big but, using them comes with a major counseling point.
Okay, listen up, because this is probably the single most important counseling point for any OTC cold product. If you use a topical decongestant for too long, you get rebound congestion. That's where the patient ends up even more stuffed up than when they started. The instruction couldn't be simpler, and it is absolutely non-negotiable. Use it for a maximum of 3 days. That's it.
All right, now we're going to move into the areas where your expertise as a pharmacist is absolutely critical. Counseling special populations, where the wrong advice can have some serious consequences. Let's kick things off with children, because the recommendations here are fundamentally different from what we do for adults. You have to be incredibly careful here. Simple things like analgesics, saline spray, and honey for kids over 1 are fine, but that avoid column, that's a hard stop. Health Canada is very firm on this. No antihistamines or decongestants for children under 6. There's just no benefit, and there is a real risk of harm. And of course, never ever recommend aspirin because of the risk of Rey syndrome.
Next up is another question you get all the time, and it's a sensitive one. What's actually safe to take for a cold during pregnancy?
With pregnancy, our focus is all about established safety. So first-generation antihistamines and acetaminophen are generally considered safe bets. Topical decongestants are also an option, but only if that 3-day rule is strictly followed. You'll want to advise caution with oral decongestants, especially in the first trimester, because the data is a bit mixed. And it's best to recommend avoiding high-dose vitamins and certain herbals.
And for our last special population, let's cover breastfeeding. Here the goals are pretty clear. Minimize the baby's exposure and avoid messing with the milk supply. For breastfeeding moms, local therapies are king. Intranasal saline, topical decongestants, these are preferred because very little gets absorbed systemically. Now, if a systemic drug is being considered, you've got some crucial counseling points. First-gen antihistamines might make the infant drowsy, and you have to warn them that pseudoephedrine has been shown to potentially reduce milk supply.
All right, let's do a quick fire round on the stuff that patients might ask for by name, but that the evidence tells us you should confidently advise against.
First and foremost, antibiotics. The common cold is a virus. Antibiotics kill bacteria.
They will do absolutely nothing for a cold, and their overuse is a huge public health problem. This is a clear, simple, evidence-based no.
So what about that annoying cough? Well, for a simple cold, the evidence just isn't there to back up using antitussives like codeine or dextromethorphan. And as we already saw, they're a definite no for kids.
And finally, the big three from the natural health products aisle.
Look, while they might be popular, the science as it stands today just isn't strong enough to recommend vitamin C, echinacea, or vitamin D for actually treating a cold that's already started.
Okay, so we have covered a lot of ground. Let's boil it all down now into 4 memorable, actionable points you can use with your very next patient.
It really all comes down to this. First, target the symptom. Tell your patients to treat their stuffy nose or their headache, not the cold. Second, always preach the 3-day rule for topical decongestants. Third, shield the children. Be firm about no antihistamines or decongestants for any kid under 6. And finally, reject the ineffective. Be confident when you explain why things like antibiotics just won't work. These 4 points are your foundation for excellent, evidence-based care.
So, the final question really is for you. The next time a patient comes to you and asks for something strong for their cold, how are you going to use this framework to completely change that conversation and guide them to a much better, safer outcome? Thanks for watching.